Assalamu alaikum. Good morning, students. As you all know, we were reading about the respiratory system. In my last class, I have already discussed about the obstructive pulmonary diseases that include emphysema and chronic bronchitis. Today, I will discuss about other two diseases of obstructive lung disease and infective lung disease. Let's start with asthma. What is asthma? Asthma is a chronic inflammatory disorder of the airways that causes recurrent episodes of wheezing, breathlessness, chest tightness, and cough, particularly at night or in the early morning. So, the hallmarks of asthma are increased airway responsiveness to a variety of stimuli, resulting in episodic bronchoconstriction, inflammation of the bronchial valves, and increased mucus secretion. So, there will be constriction of the bronchus along with inflammation of the bronchial valves, and mucus secretion will be increased. Ultimately, there will be episodes of wheezing, breathlessness, chest tightness, and cough. So, asthma may be classified as atopic asthma and non-atopic asthma. Atopic asthma. It is the most common type of asthma. There will be a positive family history. It begins in childhood and evidence of allergen stimulation. For example, there will be presence of allergic rhinitis, eczema. Type 1 or immunoglobulin E mediated hypersensitivity reaction. The atopic asthma is triggered by environmental allergens like dust, pollen, food, and animal dander. A skin test for offending antigen result in a wheal and flare reaction. So, atopic asthma will have a family history, and actually it is a type 1 or immunoglobulin E mediated hypersensitivity reaction. And there will be other associated atopic diseases like allergic or atopic rhinitis and eczema. And what is non-atopic asthma? There will be no family history or uncommon family history, does not have allergic sensitization, and triggered by viral infection. For example, rhinovirus, parainfluenza virus, and the skin test will be negative. Then let's come to bronchiectasis, another obstructive lung disease. Bronchiectasis is characterized by permanent dilation of bronchi and bronchioles caused by destruction of muscle and elastic tissue resulting from or associated with chronic necrotizing infection. So there will be a history of infection, and ultimately there will be destruction of the muscle and elastic tissue of the bronchus and bronchioles, resulting in permanent dilation of the bronchus and bronchioles. The conditions that are associated with bronchiectasis include congenital. These are cystic fibrosis, intralobar sequestration of the lung, immunodeficiency state, primary ciliary dyskinesia, and Carter-Jenner syndrome. Infective causes may include necrotizing pneumonia by bacteria, for example, Mycobacterium tuberculosis, Staphylococcus aureus, Haemophilus influenzae, Pseudomonas. Viruses include adenovirus, influenza, and HIV virus. Fungus include Aspergillus. Bronchial obstruction may also lead to bronchiectasis. Bronchial obstruction may result from tumor, foreign bodies, and occasionally from mucus impaction, in which the bronchiectasis is localized to the obstructed lung segment. Other causes include rheumatoid arthritis, systemic lupus erythematosus, inflammatory bowel disease, and post-transplantation. So, clinical features of bronchiectasis include severe persistent cough, expectoration of foul smelling, sometimes bloody sputum, dyspnea and orthopnea in severe cases, and occasionally life-threatening hemoptysis. So what are the complications of bronchiectasis? There may be development of cor pulmonale, brain abscess, and amyloidosis. Now, I will discuss about restrictive lung disease shortly. Restrictive lung diseases are characterized by reduced expansion of lung parenchyma and decreased total lung capacity. These occur in two general conditions: chronic interstitial and infiltrative diseases like pneumoconiosis, interstitial fibrosis, and chest wall disorders including poliomyelitis, severe obesity, pleural diseases, and kyphoscoliosis. Chronic diffuse interstitial diseases. What are these? Chronic interstitial pulmonary disorders are a heterogeneous group of disorders characterized by inflammation and fibrosis of pulmonary interstitium. So there will be inflammation and resulting in fibrosis involving the interstitium of the lung. These are known as diffuse interstitial diseases. There are some categories. Number 1 is fibrosing. These are idiopathic pulmonary fibrosis, non-specific pulmonary fibrosis, cryptogenic organizing pneumonia, pneumoconiosis, and radiation pneumonitis. Then granulomatous. Granulomatous causes include sarcoidosis, hypersensitivity pneumonitis. Then eosinophilic may occur. Then smoking related, and others include Langerhans cell histiocytosis, pulmonary alveolar proteinosis, and lymphoid interstitial pneumonia. Then let's discuss about pulmonary infection. Pneumonia. Pneumonia may be defined as inflammation of the lung parenchyma. There are two major types of pneumonia. These are etiological classification and morphological classification. Etiological classification or pneumonia syndrome. It is divided as community acquired acute pneumonia. The causative organisms include Staphylococcus, Streptococcus pneumoniae, Haemophilus influenzae, Moraxella catarrhalis, Staphylococcus aureus, Legionella pneumophila, Enterobacteriaceae including Klebsiella pneumoniae and Pseudomonas species, Mycoplasma, Chlamydia, and Coxiella barneti. There are some viruses including respiratory syncytial virus, parainfluenza virus, human metapneumovirus in case of children, influenza A and influenza B virus in case of adult, and adenovirus. It is mainly seen in case of military recruits. Then second type of etiological pneumonia is healthcare associated pneumonia. The causative organisms are Staphylococcus aureus, which may be methicillin sensitive or methicillin resistant. Then Pseudomonas aeruginosa, then Streptococcus pneumoniae. The third type is hospital acquired pneumonia. The organisms are gram-negative rods, Enterobacteriaceae like Klebsiella, Serratia, Escherichia coli, and Pseudomonas. Then Staphylococcus aureus, usually methicillin resistant. Then the fourth type is aspiration pneumonia. Aspiration pneumonia may be caused by organisms including anaerobic oral flora that includes Bacteroides, Provotella, Fusobacterium, and Peptostreptococcus, and some aerobic bacteria including Streptococcus pneumoniae, Staphylococcus aureus, Haemophilus influenzae, and Pseudomonas aeruginosa. Then another type is chronic pneumonia. Chronic pneumonia occurs by organisms including Nocardia, Actinomyces, Granulomatous. For example, Mycobacterium tuberculosis, atypical Mycobacteria, Histoplasma capsulatum, Coccidioides immitis, and Blastomyces dermatitis. Then necrotizing pneumonia and lung abscess. anaerobic bacteria with or without aerobic infection, and Staphylococcus aureus, Klebsiella pneumoniae, Streptococcus pyogenes, and type 3 pneumococcus. Then the last one is pneumonia that occur in immunocompromised host. The causative organisms are cytomegalovirus, Pneumocystis zero-vesi, Mycobacterium avium intracellulare, invasive aspergillosis, invasive candidiasis, and usual bacterial, viral, and fungal organisms. So, the etiological classification includes community acquired acute pneumonia, healthcare associated pneumonia, hospital acquired pneumonia, aspiration pneumonia, chronic pneumonia, necrotizing pneumonia and lung abscess, and the last one is pneumonia in immunocompromised host. Then let's come to morphological classification. On the basis of anatomical distribution within the lung parenchyma, pneumonia is classified as lobular bronchopneumonia and lobar pneumonia. Lobular bronchopneumonia. It is characterized by patchy consolidation through one lobe but is more often multilobar. It is frequently bilateral and basal. On histological examination, there is suppurative neutrophil rich exudate fills the bronchi, bronchioles and alveolar spaces. So, in case of lobular bronchopneumonia, there will be patchy consolidation that involves one lobe but more often it is multilobar. This is a picture showing bronchopneumonia and lobar pneumonia. In case of bronchopneumonia, we can see that there is patchy involvement of the lung parenchyma, and in case of lobar pneumonia, there is involvement of an entire lobe of the lung. So, what is lobar pneumonia? As I have already discussed, fibrinosuppurative consolidation of a large portion of a lobe or entire lobe is defined as lobar pneumonia. There are 4 stages of lobar pneumonia. What are the stages? Stage of congestion, stage of red hepatization, stage of gray hepatization, and stage of resolution. So, in case of stage of congestion, the lung is heavy, boggy, and red. It is characterized by vascular engorgement, intraalveolar fluid with few neutrophils, and often the presence of numerous bacteria. So, it is the first stage of lobar pneumonia and it is known as stage of congestion. Mainly there will be presence of neutrophil and numerous bacteria within the alveolus. Then the next stage is stage of red hepatization. It is characterized by massive confluent exudation with neutrophils, red cells, and fibrin filling the alveolar spaces. So, along with the neutrophils, there will be accumulation of red cell and fibrin within the alveoli in the stage of red hepatization. Then next stage is stage of gray hepatization. The lobe appears distinctly red, firm and airless with a liver-like consistency, hence it is known as hepatization. It follows with progressive disintegration of red cell and their persistence of fibrinopurulent exudate. Gross appearance become grayish brown with dry surface. So, in case of gray hepatization, the lobe will be firm and hard, hence it is called hepatization, and there will be disintegration of red cells and accumulation of fibrinopurulent exudate. Then the last stage is stage of resolution. The consolidated exudate within the alveolar spaces undergoes progressive enzymatic digestion to produce granular semifluid debris that is resorbed, ingested by macrophages or organized by fibroblasts growing into it. So, in case of stage of resolution, there will be resorption of the debris and fibroblast growth. This is a photomicrograph showing acute pneumonia. Here we can see that within the alveolar spaces there is accumulation of acute inflammatory cells, that is neutrophil, along with many RBCs. This is a photomicrograph showing organizing pneumonia. In this case, there is gradual disintegration of acute inflammatory cells, accumulation of macrophages, and there is development of fibrosis. This is a case of organized pneumonia. Here we can see that there is more advanced stage of fibrosis and disintegration of inflammatory cells and cellular debris. Now we will discuss about the difference between lobar pneumonia and lobular bronchopneumonia. The definition I have already discussed. Lobar pneumonia, there will be fibrinosuppurative consolidation of a large portion of a lobe or entire lobe. And in case of lobular bronchopneumonia, there will be patchy consolidation through one lobe or through multi-lobe. The age in case of lobar pneumonia more common in adult, and lobular bronchopneumonia is more common in extreme age, that is infant and adult. Predisposing factors include, in case of lobar pneumonia, more often affect healthy individual, but in case of lobular bronchopneumonia there will be pre-existing diseases. The etiological agents in lobar pneumonia are mostly pneumococci, Klebsiella pneumoniae, Staphylococcus, Streptococci. And lobular bronchopneumonia, the etiological agents are Staphylococcus, Streptococcus, Pneumococcus, and Haemophilus influenzae. Stages. In case of lobar pneumonia, there are 4 stages, and in case of bronchopneumonia, no definite stage is present. The prognosis is better in case of lobar pneumonia, and complications are more common in case of bronchopneumonia. There may be development of bronchiectasis and other complications. Clinical features of pneumonia. There will be high-grade fever, productive cough, occasional hemoptysis, pleuritic chest pain, and shortness of breath. Laboratory diagnosis that aid in the diagnosis of pneumonia, we can do complete blood count including total count, differential count of WBC, ESR, then CRP, then X-ray chest PA view that shows homogeneous opacity, and sputum, gram stain, acid fast stain, and blood culture and sensitivity. Complications of pneumonia. There may be abscess formation resulting from tissue destruction and necrosis, particularly common with type 3 pneumococci or Klebsiella infections. Empyema. Spread of infection to the pleural cavity causing the intrapleural fibrinosuppurative reaction. Then bacteremic dissemination to the heart valve, pericardium, brain, kidney, spleen, joint causing metastatic abscess, endocarditis, meningitis, and suppurative arthritis. Then there may be development of pleural effusion, organization, and bronchiectasis in case of lobular bronchopneumonia. So that's all for today. We will continue the respiratory system in the next class, the remaining portion. Thank you so much.